Go around, then I will need you guys to fill out the front, and I'm the clinical sales support person for the LTV ventilators series. Actually, I hold contracts with 3 different manufacturing companies and represent their products. CareFusion 203 is one of those, and they have the LTV series of ventilators. We also have 2 other ventilators, one called the Revell, one called the Envy. They are mostly hospital transport and helicopter transport ventilators. You will mostly see them, the Revell, you'll mostly see on helicopter transport or ground transport teams, and the Envy in hospital transport. They're a little more expensive ventilator than your home care vet. I started doing these classes I'm a respiratory therapist by background. I started doing these classes in 2007 when I took over representation for the company. My background is I started at Cardinal Glennon Children's Hospital long time ago. In 1989, I came there as a student, started there as a therapist in 91, worked on the transport team in the ICUs, worked in industry for a few years, and then I helped to open Rankin Jordan Pediatric Hospital from 2005 to 2004 to 2006, and then opened Spiritus after that. So worked in both subacute care, critical care. I also did some per diem for Apria Healthcare when I was going to grad school. So I've kind of worked in all different facets of it. We started doing these programs, like I said, in 2007, right after I started Spiritus, because in my experience in working with trying to get particularly pediatric patients, but also adult patients home that were ventilator dependent, there was a big gap there in the educational process. So how many of you guys have already worked with a vent patient in their home? Everybody. Okay, awesome. And have you guys had a class, a ventilator class before? Specific ventilator class?
From you.
Some people, yeah. What I found in working in the area was that a lot of people, nurses in particular, felt very uncomfortable working in a home ventilator situation. I always tell people that's not your fault. The system really isn't designed to help you be prepared, unfortunately, because most nurses get LPN school. You get about 2 hours if you're lucky on ventilation. RN school you get about a day. If you're lucky, some programs a day and a half. And then you get out of college and you go to work in a hospital where, if you are fortunate to work in an ICU setting for a period of time, every time the ventilator so much as makes a noise, you call respiratory therapy or they come running in and they fix it, and then they go back out the door. And so you never find out why it alarmed, why it did what it did. And then you get booted to the curb in home care, and all of a sudden you're supposed to be the home ventilator expert, right? And there was really no one in my experience really working with nurses specifically on this. So we started with it as a challenge. These classes are free of charge to all nursing agencies. We asked that you get a group together, and so myself, I have 3 per diem respiratory therapists that work with me: Ramona Johnson, Blake Anion, and Brian Egemeyer, all who have fantastic clinical experience. Cardinal Glennon, Rankin Jordan, University of Missouri. Blake's from the University of Missouri originally, so really good experience, and they help me to provide as many of these classes as we possibly can. So what we're going to do today is we're going to, just to make sure that everybody's on the same page, and I love that you guys all have some vent experience, so we might be able to breeze through some of these first few slides. The slides that we're going to go over, you guys, I will kind of breeze through some of this stuff. If you have a question about it, or I am using an acronym that you don't know, do not feel bad. Please, please, please raise your hand. Diana's taping this, and I don't want to assume that you guys, or that every nurse who listens to this in the future will know what I'm talking about or acronyms. So if you have the question, guaranteed somebody else will down the line, so please do ask. So we're going to spend a few minutes on the first portion on just making sure everybody's on the same page with terminology. Then we're going to go to the ventilator. We're going to detail the ventilator. And then we're going to spend some time looking at the 5 buttons every nurse should know. The ventilator looks a little overwhelming when you see it for the first time because there's a lot of lights and buttons, but there are really only 5 primary buttons that nurses need to know. And then we'll look finally at some troubleshooting and messages, error messages that you might see. And if we have some time left over at the end, not only will I be happy to take questions, but we can do some scenarios and that kind of thing if you guys want to do that. So let's go ahead and jump right in with looking at the modes of operation of a ventilator. First of all, there's a lot of terminology that we need to understand. You guys probably have all heard somebody say, what mode of ventilation is the patient on? That really is a word. The mode of ventilation encompasses a lot of things. So we're going to break down each one of those pieces of the information that we need to know about what mode of ventilation a patient is on for you to be able to clearly understand all the pieces that make up a mode of ventilation. So the first one is breath type. So we have to know what breath type the patient is getting. So there are really three primary breath types available on ventilators these days. The first one is spontaneous. Means exactly what it sounds like it means. It means that the patient is able to breathe spontaneously on the ventilator. Now, if I'm going to take you guys back a few years, I don't know if there's anybody who remembers the old ventilators in the home, but the LP10s, the PLVs, the old home ventilators were a little bit different than our home ventilators today. So my little story about this is that when I started at Cardinal Glennon 1990, 1991, we had a hallway at Cardinal Glennon called TCU, Transitional Care Unit. They still have that today, but it does not look the same as it looked in the early 90s. In the early 90s, not only was it a big long stretch hallway with rooms on each side, but we had kids in almost each of those rooms who lived with us. They stayed with us. Many of them were born, came right to Cardinal Glennon right after they were born. They had never been home, were with us 4, 5, 6 years. The main reason for that is that our technology in the hospital was very advanced. We were able to keep alive pretty darn sick kids and help them to survive. What we didn't have was ventilators that could support them at home. So all we had was the big old LP10s and PLVs, and those ventilators, when patients were trying to breathe spontaneously on them, didn't have something that our ventilators today have, which is what we call flow-by or bias flow. So they didn't have flow going through them all the time. They were not flow triggered. We'll talk a little bit more about triggering. Flow triggering is the easiest way, and in the literature is the best way to ventilate a pediatric patient because very small amounts of flow being taken away from the circuit denote the patient trying to breathe, and then it supports the patient. So it helps to synchronize with the patient. So what we used to have years ago, we didn't have that. And so, we would try to take them off of our hospital ventilators and put them on a, say, LP10, for example, and they would fail right away because the ventilator couldn't synchronize with them because they couldn't drop the pressure across the whole circuit. And so they lived with us. In the mid to late 90s, ventilators started coming out with flow triggering, and that really changed everything. For home nursing, for ventilator-dependent folks, particularly kids, because now we were able to take those kids who might have lived at the hospital for 5 or 6 years and send them home. So they still have TCU at Glennon. They still have a similar unit at St. Louis Children's, but we don't have kids that live in the hospital now for years. Now you get them. So that's why, a lot of people say to me, I feel like we're getting sicker and sicker kids at home. You are, because before, those kids would have been much older before they were able to go home because we just didn't have the technology. So it really does put a lot of pressure on home nursing, unfortunately. Or some people say fortunately, they like taking care of those little more fragile kids and seeing them thrive in the home. I'm a big believer in getting them home. That's why I was excited when Dr. Holtkamp called me about Rankin Jordan building their new hospital. I really believe that kids thrive when they're in a home setting. Not because we do a terrible job at Glennon or Children or Mercy, but because it's different than in the home. And you guys see that every day, so that's not news to you. So I go through all of that to help you guys understand that spontaneous breathing on a ventilator is not what it used to be. Spontaneous breathing on a ventilator is much more comfortable for patients. The second type of breath type we have is supported. And this is also a big piece of why we can take home sicker patients today than we could years ago. is because we used to really only have one kind of supported breath. Now we have two. The first type of supported breath, and essentially a supported breath means that the patient initiates the breath and then the ventilator is in some way going to contribute to that patient's breathing. So in the first type of supported breath, we have assist control. And assist control is that when the patient triggers the ventilator, and again, ventilators these days, much easier to trigger than our ventilators of old. But when the patient triggers the ventilator in an assist control breath, the ventilator jumps in and completely takes over for the breathing. It gives a full, big ventilator breath, whatever that has been set in volume or pressure, and it sort of takes over for the breathing of the patient. The newer type of supported breath that we've had since the mid to late 90s is called pressure support. And in pressure support, again, the ventilator has to recognize that the patient's trying to take a breath, but as soon as that occurs, the ventilator this time, instead of jumping in and taking over for the patient's entire breath or responsibility for the size of that breath, the patient has some control over that. So in pressure support, when the patient triggers a breath, the ventilator just jumps in and gives a little boost of pressure. So when we have a patient on pressure support, you're going to hear a number associated with that. And that's in centimeters of water pressure, and that is the amount of pressure that the patient is going to see, that their chest is going to see when a breath is triggered. So again, two supported breath types, assist control and pressure support, okay? So let's start by asking a question. If you have a patient that you are going to try to wean off the ventilator, okay, so everybody's familiar with weaning off the ventilators. Keep turning the ventilator down so we can get the person off of the ventilator, or at least not on the ventilator quite so much, maybe down to just only nocturnal ventilation. So if we have that as a goal, to wean, which one of the supported breath types would we want to use? Assist control or pressure support?
Pressure support.
Pressure support, exactly right. So, for those of you who thought I don't really know very much about ventilation, you already know more than some pulmonologists in town. Because we haven't always had pressure support, and in their defense, it's hard to defend not understanding pressure support in 2013, but there was a time when we didn't have pressure support, and so our old guys and girls sometimes forget about pressure support and the ability for pressure support to do two main things. The reason why I really like pressure support, number one, it's a weaning mode, because it requires that the patient have some accountability for their chest wall movement and their breathing. So if we put patients on assist control, what happens? They get lazy. They just lay there and they let the ventilator do everything for them, okay? Unfortunately, that's part of being a human. If somebody's going to do it for us, we tend to kind of just hang out there and let somebody else do it for us. So just human nature, but our bodies are designed that way, that if something is going to take over and do it for us, we're going to get lazy. Same thing with pulmonary mechanics, okay? In pressure support, that patient has some responsibility and accountability for the breath, and so therefore they are exercising their chest wall, their muscles, both their diaphragm and their accessory muscles, and it's going to help them to get stronger and to take over more and more responsibility of breathing. Okay, so it's a great weaning. Some people say to me, well, why then would we put somebody who is a quad or somebody who has ALS, for example? They're going to succumb to that disease, right? They're not going to get any better. It's a progressive neuromuscular disease. They're going to die from it. Why would we put them on pressure support? My theory on this is, and there's some supportive literature, not a huge amount, but most people in pulmonary medicine these days say we do still want to put those folks, especially if your quads, if they have any upper shoulder movement at all, that they can help with their breathing. And especially our ALS and young men with Duchenne's muscular dystrophy, we want to put them on pressure support because it exercises them. So even though our ALS folks, we know they're going to die from that. Unfortunately, we don't have a cure for ALS. If you exercise, you tend to live longer. So they stay healthier and live longer on pressure support typically than they would if they're just put on assist control, because they'll atrophy much quicker. We do still put quads sometimes on assist control, and there's there's not really good literature on either way on that, so I won't say specifically that there's a good way or a bad way to do that. Sometimes you'll hear people say one thing or another. I'm a fan of pressure support, as you can tell, so I tend to lean towards that. The last or the third breath type that you're going to see is a machine or mechanical or mandatory. They conveniently all start with M. That is the breath that is given by the machine, completely by the machine. It is a mandatory breath. They're going to get it so many times a minute, no matter what. And when you hear about what mode of ventilation and the ventilator settings that a patient is on, if you have any type of mandatory breaths at all, you will hear people call that the rate. What rate is the patient on? So whatever that rate is, that's going to be set on your ventilator. They're going to get that number of mandatory ventilator, full ventilator breaths, no matter what. That's going to be their minimum. Now they can breathe above that, either spontaneously or supported, but they're going to at least get that amount. That's the mandatory breath rate. Next, we have to understand if they are given a breath or supported or a mandatory breath, how is that breath going to be given? Is that breath going to be a volume breath or is it going to be a pressure breath? Okay? And really, there are only two breath types. Okay? There are some hybrids on our ICU vents these days, and there are some hybrids on some different types of devices that are we're starting to see them in the home, but sometimes they're fancy names for something else, and that's what's happening here, is that there's really only a pressure style breath or a volume style breath. And so if you understand the two of those and what's important to look at in those two style breaths, this will make a lot more sense. Unfortunately, we get clouded in respiratory therapy with a lot of acronyms and a lot of marketing names from ventilator companies. And so people call things this or call things that, and everybody thinks that it does something different. I like to make it simple. Let's break it down to what it really is and talk about those things, okay, instead of talking about brand names or things that ventilator companies have named it. So, volume or pressure breath. If the patient gets a volume breath, what that means is that with each one of those mandatory breaths, or if we have it in assist control, an assisted breath, it is going to be given in a specific volume. Okay, so say for example, I have somebody on assist control with a rated 10 and a tidal volume of 200 milliliters. That means that 10 times a minute, no matter what, they're going to get a 200 milliliter breath, right? And because I said assist control, what happens if they try to they initiate their own breath? What do they get? The vent takes over. They get 200 milliliter tidal volume, right? Okay, good. Everybody's following along with that, great. So that's going to be a volume breath. So what do we need to really focus on or pay attention to of the information that the ventilator is going to give us in a volume breath? So if we're always getting the same volume, okay, and let's think of our lungs as a balloon, okay, and we're always putting the same volume into that balloon, then the number that's going to vary, or the thing that's going to be variable with the patient's ability to exhale air, so how open their airways are, as well as how stretchy their lungs or that balloon is going to be pressure, okay? So the big thing that if you have a patient in volume ventilation, the big thing you want to pay attention to or track of the exhaled patient information is going to be PIP, or peak inspiratory pressure. We're going to want to track the pressure. And here's the reason. Let's think about this. If our lungs are a balloon, and they are a big stretchy balloon, big nice stretchy balloon, with a big hole for us to blow into, nice open airways, nice big stretchy lungs, good compliance in our chest wall. Then if we shoot in 200 milliliters of volume, how much pressure is it going to take to get that volume in? Not very much, right? Because we have a nice big open hole to blow into, and we've got a nice big stretchy balloon. Now think about a water balloon. Little bitty tiny hole, little bitty tight, balloon, right? Now, we're going to try to put the same amount of volume, 200 milliliters, into that water balloon. What's going to happen? It's going to take a lot of pressure to get that volume in that balloon, right? So our lungs and our airways are the same way. If our airways are nice and open, and our lungs and our chest wall are nice and compliant, stretchy, how we want them to be, then it's not going to take very much pressure to shoot that volume in. Conversely, if our airways are clogged with mucus, or our tracheostomy tube is clogged with mucus, or our chest wall is stiff, or if we have somebody who has scoliosis and we roll them into a position where their chest wall compliance is detracted, then how much pressure is it going to take to deliver that same volume? It's going to go up, isn't it? Okay? So think about that when you have a patient that's on volume ventilation. Knowing and understanding what their PIP, or their peak inspiratory pressures are, is very important to your clinical interaction with that patient. Okay? Because if the pressures are going up, something's wrong, right? There's something's not going right. Either the chest wall is decreasing in compliance, the airways are getting clogged, there's something in that tracheostomy tube. Okay? So we need to think about that. So, if we have a patient on the ventilator, and the ventilator alarms high pressure, what are we going to do first?
Check the patient.
Suction.
Check the patient. Woo! I wish I had something to throw out and give away awards. Check the patient. So that was sort of a trick question. And now the trick's over. I'm just going to spill it. Every time I ask you, if I say the ventilator alarms, what do you do? The answer is always check the patient, right? Always check the patient. You can never go wrong if you look at the patient first. Always, always, always. Because sometimes it's blatantly obvious, isn't it? What's wrong with the patient, okay? So start with them, work your way back. Okay, start with the patient, work your way back. So the ventilator alarms high pressure. We're ventilating along, nice normal pressures, let's say in the low 20 centimeters of water pressure, and all of a sudden the pressure shoots up, alarms high pressure. We look at the patient. What do you guys think big thing it probably is? Coughing. Or the patient needs suctions, right? They got a big loogie. So we look at them and whoop, there it is. It's, right there. So we know immediately that the problem probably is that loogie. And so we're going to suction them. We're going to give them some time to recover, and we're going to look at those pressures. Did they go back down? Did we fix the problem? Hopefully we did. If we didn't, keep looking. Okay? Maybe it wasn't the tracheostomy tube. Maybe it was, or it was a combination of the tracheostomy tube and the positioning of the patient, or it was the tracheostomy tube and something occluding this ventilator circuit, okay? So start with the patient, look at the obvious, try to deal with that first. Did it solve the problem? If it didn't, we're going to keep looking. We're going to keep digging into it until we get those pressures back down on that volume ventilated patient. Now, what about this scenario? And this is the reason why nursing and ventilator flow sheets in the home are so important. I know you guys have a document that you write. You have your nurses write down some stuff off of the ventilator. The main thing in volume ventilation that we want to make sure they fill in the box on, we have to fill in the box on everything for litigious reasons. But the main thing from a clinical perspective on a volume ventilated patient we want to pay attention to is that PIP. Because here's something that in the documentation piece is going to be very helpful to you. If you have a patient on volume ventilation, and let's say they're ventilating with PIPs in the mid to low 20s, okay, so let's say 22, 23 is about how much pressure it's take to ventilate that patient. And you come on to shift, and you do your assessment, and you look at the patient, and you write down all the stuff from your ventilator sheet, and we're ventilating 22, 23. And do you guys document that every 4 hours or every two? Every two. Okay, so 2 hours later, you're ventilating at 23, 24, looks good, everything seems to be fine. We're ventilating along. By the end of your shift, the ventilating pressure is, let's say 28, 26, 28, something like that. It's pretty consistent. That's not a big jump. 22 to 26, 28, and it's not really a big jump. Sometimes it has to do with whether the patient's upright, or in a chair, or how they're positioned. Maybe it has to do with feeding, when they get a feeding, right. If they've pooped, that's a great one. Getting poop out helps to get the diaphragms down sometimes and ventilate better. So once they've had a poop, sometimes they ventilate a lot better. So all of those kinds of things, and feedings, if you bolus feed, feedings can deter that. So all kinds of things can cause small variations in the pressure. So we're not going to be terribly concerned over 23 to 28. But I sign out and I sign into to my counterpart. They come on shift, or maybe parents have a few hours of shift, and then it goes to a nurse again. And the next documentation starts at 28 or 30, and now that's their baseline. And then at the end of their shift, we're ventilating at 34, 32. So we went from 28 to 32, not a big deal, right? If we're living in that vacuum. And then the next person starts at 34. You see where I'm going with this, right? So that's why documenting PIP on volume ventilated patients over time and paying attention to it. I know at the beginning of a shift is usually hectic because you're trying to do your initial assessment, you're trying to get your arms around everything that needs to be done, get your plan of action in your mind. But when you have an opportunity, it is always good to go flip through those vent sheets and see, especially on a volume ventilated patient, focus on that PIP. What's been happening with that over the last 2 or 3 shifts or 2 or 3 days? So let's think about that for a second. If we had a patient that was occurring with, what's some things that we think might cause that to slowly increase over time? Anybody have any ideas, clinical things that could be going on with the patient?
Maybe aspiration.
Aspiration, anything that could cause a pneumonia, right? Or atelectasis are 2 biggies, okay? A third one is biofilm buildup on the inside of the tracheostomy tube. So let's deal with those one at a time. Let's start with pneumonia, an aspiration, or a bacterial or viral pneumonia. Usually what those are is something feeding bacteria-ridden mucus, viral-ridden mucus, in the alveolus, or blocking really small airways, causing our alveolus to be full of something. Snot, schmooze, right? So what happens? Well, that bacteria-ridden mucus is in the alveolus, and so when we push that 200 milliliters of air in there, those alveolus don't get to participate because they have something in them, causing the pressure to go up with the ventilator. Okay, so tracking that over time, looking at when this started to occur in conjunction with feedings or in conjunction with anything else that's happening. Just because we have a patient on a ventilator and we're going to have lots of good data about the patient's breathing doesn't mean we throw out all the rest of our nursing assessment skills. We're still going to look at a blood pressure and a temperature and a heart rate, that temperature and heart rate and blood pressure together sometimes can give us really good information. Significantly elevated temperature with an increase in blood pressure and heart rate and an increased PIP, boy, that's looking like a bacterial pneumonia, isn't it? Yeah, because those are things that would cause all 3 of those things to go up. Okay, so looking at that, thinking about those kinds of things will help you with your clinical assessment. The second one, atelectasis. What's the difference between pneumonia and atelectasis? Pneumonia is usually something in the alveolus, some sort of schmooze. Atelectasis is actually collapse of the alveolus, right? So the alveolus have collapsed. The number 1 cause of atelectasis in patients in what we call the middle space, outside of acute care, is actually the thing that we think we should be doing with pneumonia. So this is why this is really important that you guys think through this clinically. It's suctioning. Overzealous suctioning causes atelectasis more than anything else. Why? Well, because if somebody is on a ventilator, there's a reason for that, right? And it usually has something to do with the fact that the lungs aren't able to operate well on their own. And so especially in patients that have higher PEEP levels, positive end expiratory pressures, okay? If their PEEP is over 5 centimeters of water pressure, we need to be very mindful when we suction. The reason is because if they've needed or we've determined that they require a lot of positive end expiratory pressure, a lot of pressure left in the chest when the patient's done breathing, then we don't want to be sucking it all out. Okay? So what happens when we suction? Well, we go down in there and the goal is to get the schmooze, right? Is to get the mucus out of the airways. What also happens with it is that we suck their air out. Okay? Can't help it. You're suctioning and you're going to suck the air out. So a couple little tips that I like to give people with suctioning. You guys have probably heard some of these before. One of them is train your nurses that when they go to suction, if they're not sure until they get used to it, hold their breath. When you go down to suction, hold your breath. If the patient if you can't hold your breath anymore, guess what? Neither can they. Okay? So if you hold your breath, it gives you a little sort of tracking in the back of your mind about how long you should be down there. Okay? You should not be down there for a long time, because all you're doing is sucking all their air out of them, and you're going to end up with atelectasis. Okay? The second thing with suctioning is disconnecting the ventilator on patients with high PEEPs. Okay? And actually, this is why we're going to start using the pig lungs at the training at St. Louis Children's, is that we want to demonstrate that to people. I have a real set of pig lungs, and we ventilate them on a ventilator for a while, and we show that with PEEP, how they get nice and light pink and they're ventilated up here, and then we disconnect them from the ventilator and we show what happens. And you can literally see it. You can see all the, they get real dark red and they just collapse down. And if you think about when you're disconnecting somebody from the ventilator, that is particularly somebody who is PEEP dependent, a lot of PEEP to ventilate them, when you disconnect them from the ventilator and then you go suck whatever air they have left in them out, you're just adding to the potential for collapse. Whether the PEEP is added to keep the alveolus distended, sometimes we have higher PEEPs because they have malacia or collapse of the mainstem bronchus or the trachea. And so either way, that PEEP is there for a reason. So what I like to recommend to people is suctioning through a PEEP keep or closed suction. Closed suction used to be something we rarely could get into home care because it was so expensive. There are new closed suction systems out there that are very inexpensive. It's actually less expensive on somebody who needs to be suctioned a lot to use some of the newer type of closed suction systems. So if your patient or your nurses are telling you, this kid desats after suctioning and it takes forever to re-recruit them, are they suctioning with closed suction or through what I call a PEEP keep? This one doesn't have it, but these swivels sometimes have a little duckbill valve, and you pop it open and you can actually suction through there. That's what I recommend for those kinds of patients, because it's going to take them a long time to re-recruit if you disconnect them from the ventilator. Okay? When we go through buttonology, one of the main 5 buttons that every nurse should know is manual breath. That's the reason. We'll talk about that more. But you do not, this day and age, you do not need to completely disconnect people every time you suction them to bag. Okay? Another just little dig here, pet peeve of mine with suctioning is saline. And a lot of people say, well, but I was trained that way, that you were supposed to squirt a 3 cc of saline down, bag the patient, and then suction them. And I always say, yeah, well, we used to put leeches on people and put them in iron lungs, too. We figured out that really wasn't a very good way of doing it. Because what we were doing, and really it's a common sense thing, but it's since been researched. Actually, a doctor who used to be at Cardinal Glennon years ago published a bunch of research on this, that what's happening is that you're squirting saline down there. Remember I mentioned earlier about biofilm building up on the inside of the tracheostomy tube? So biofilm building up on the inside of the tracheostomy tube is schmooze with bacteria in it. Okay? So if we take a saline bullet and we squirt that down the kid's trach, and there's biofilm in there, and the stuff goes down, if we don't go get it really quickly, what happens? It gets down into the small airways. Now, add that thing that, listen, I did it in 1989. We thought it was the way to do it. We then bagged them on top of it. So now we're not only squirting saline through the biofilm, we're loosening the biofilm, we're shooting it down into the mainstem bronchus. Now we're bagging it down as far as we can get it. So there is no way that we could get it back up out of there, even if we had the best suctioning technique possible, okay? So don't do that. Don't ever do that. If someone insists on using a few drops of saline with suctioning, a few drops of saline with suctioning, and you go get it right away, okay? You let it sit down there, you bag it in, you are asking for pneumonia. You are asking for atelectasis because you are going to shoot that stuff down in there and you're not going to be able to get it back out.
Can I give you a mom's phone number to call?
Be happy to. Actually, if you guys do have a lot of controversy around this, this is one of the areas that is very well documented in the literature. Happy to get you articles on it. Happy to get you articles on it. Okay?
I've been there 20 years and I have done that so many times.
Yep.
It's not even.
I worked
Yep.
at that mom's house before I was in this position, and I did it because
That's
she
what
said
everybody
she was-
said to do.
yes, she said she was trained to do it that way. at the
And she may have
hospital.
been in
No,
1989
this
or
child's
19.
only been in a vet for 3 years.
Yeah. Then
She went to
unfortunately,
Baltimore. Where did she go up in Baltimore? Somewhere.
yeah. Unfortunately, I'm a respiratory therapist. I'm going to diss on us a second. There's a lot of us that respiratory therapists that were trained stuff in the 80s and have lacked to pick up a journal and really follow up on this kind of stuff. And I'm very in tune to it because of kind of how my clinical practice has gone, and also because I worked under Dr. Bruce Rubin at Cardinal Glennon Children's Hospital, who is a world-renowned pulmonologist, who is literally, he used to, when he worked here at Glennon, his license plates on his car, on his Mazda Miata, said mucus. He loves mucus. He is the mucus doctor, and he speaks all over the world about his research on mucus. He had a little frog mucus project when he was here at St. Louis. He's a little quirky individual, but he's a brilliant man, and he really believes in and really digging into why we do things that we do, and not taking for granted that because I was taught that way at some point that I should just always do it that way. And so he is in the forefront of looking at mucus clearance devices on the market like IPV and the chest vest and the cough assist
Yeah,
devices.
she uses the cough assist.
Yeah, cough
too.
assist devices. You know, he's done a lot of research on that, and he's also done a lot of research on the simple stuff like bagging down saline, you know, and how detrimental it is to patients. So, so that one, I'm happy to pull you literature on. So, and when I do presentations too, guys, I will tell you that some things are my opinion and things that I have experienced over the last 21, 22 years, and some of them are very literature-based. And the literature-based stuff, I say go to the mat over it because it really, I mean, we have proven documented literature that says this is the right way or the wrong way. Some things, there's more than one way to get to the arch. You know, there's more than one way to do things, and some of it is opinion until the research proves it right or wrong. Okay. So the second thing we talked about is atelectasis for slowly increasing PIPs. That one you're going to deal with clinically differently than you do the pneumonia, but they're going to present very close to the same. Usually, if you have atelectasis, you will not see high fevers. You will see a very low-grade temperature increase from baseline. So that's usually your big trigger that it's atelectasis versus pneumonia. Or you have documentation, or you saw it happen. Somebody suctioning the bejesus out of them, and 4 hours later, you know, or they had a decannulization, and we had a difficult time getting that tracheostomy tube back in, and 4 hours later, 5 hours, 6 hours, 10 hours later, we're seeing higher PIPs, a low-grade temp. We're starting to see these things that might give us an indication that we've had some alveolar collapse. Okay, so how they're going to treat those are different. The third one is the biofilm buildup. That's pretty self-explanatory. You know, when you go to suction a kid with a small tracheostomy tube, that's why we like to suction. We go into a certain length. Here's another thing we used to do years ago. We had to go down until they coughed really big, right? We used to go down until they coughed really big because we were touching the carina and we were creating a cough. What we didn't realize was we were also creating scar tissue on their carina. Okay, and so when we go to decannulate those kids someday permanently, we got all kinds of problems, and we have to laser their trachea and their carina and everything to fix that because we've damaged it. So we go down to a length these days. You should all your nurses should know what the length is, and it's going to be different from patient to patient because you're suctioning through different stuff, adapters and all those kinds of things. So you're going to need to know what that is. We're going to suction. We're going to go down. We're going to hit the suction and then back up, and then we're going to try to twirl it if we can at all. It's a little more difficult with closed suction than it is with open, but any movement that you can get, and essentially what you're trying to do is move that catheter tip around inside of the tube so that we're suctioning out the inside of the tube on the perimeter. Because sometimes if you go straight down and straight back out, you make a nice little hole straight down and straight back out, okay? So when you're doing that, you're going to want to always make sure that you try to give it a little swirly swirl so that you're getting that biofilm off the inside of the inner diameter of the tube, okay? So those are our three things on PIP, on volume ventilation. The second type of breath that we can give is a pressure breath. And a pressure breath, this time instead of giving a fixed volume with each one of those machine breaths or assisted breaths, we're going to give a certain pressure. So it's sort of converse of what we just looked at. We're going to give a certain pressure, and with our ventilator, that pressure is over the top of PEEP. Okay? So we'll revisit that here in a second. But let's say it's 15 centimeters of water pressure with a PEEP of 5. Then our normal peak inspiratory pressure should be about 20 on an LTV ventilator with internal PEEP, with dial-in PEEP, okay? If it's on the older style of LTV that has an external PEEP valve, when you set the pressure, that is actually the peak inspiratory pressure, okay? So if I set it at 15 and I dial in a PEEP of 5, now my peak inspiratory pressure is still only going to be 15, my PEEP is 5, so my change in pressure, or my delta P, my ventilating pressure, is only 10. Okay? So with that ventilator, with our older style ventilators, which is what is called not PEEP compensated, when you set the pressure, it is the maximum pressure the patient will get on a pressure breath. On our new style ventilators, the 1100 and the 1150, they are PEEP compensated. They work just like an ICU vent. And so when we dial in a pressure, it is on top of PEEP. So if I dial in 15 and I have a PEEP of 5, I'm going to hit 20 as my PIP. If I turn my PEEP up to 10 and I still have 15, now I'm going to be at 25, okay? On that ventilator, or any other ventilator that is not PEEP compensated, if I have a pressure of 15 and a PEEP of 5, I'm going to hit 15, and I've got a ventilating pressure, or delta P, of 10. Now if I turn my PEEP up, I just fixed my oxygenation problem by turning my PEEP up, but what did I do to ventilation?
Got it.
I decreased it, right? If you guys get that piece right there, trust me, you definitely get more than some RTs and physicians. I have this problem all the time when they're dealing with a not PEEP compensated ventilator. That is not the only not PEEP compensated ventilator on the market. We don't sell that ventilator anymore. We have gone to the critical care style of ventilators that are PEEP compensated, but there's still a lot of those old guys out there.
Yeah.
And there will be for a long time because they're really good ventilators. You can't hardly kill an LTV ventilator. They are very durable vents, okay? Question.
This one says an LTV 900, what's,
Yep.
is that
This one is an
1150?
1150.
Okay.
So the 1150 and the 1100,
Are
the PEEP is inside the
Okay.
ventilator, and so it is PEEP compensated. On our older ventilators, that have an external PEEP valve that you have to screw in,
Uh-huh,
that is not PEEP
right,
compensated.
that's what I'm
Yep.
used to, is the,
Yep.
with that, yep.
Yep, with the external PEEP valve. Now, I will say this, and I rarely comment or make comment on other people's ventilators because it's just not my place to do that. But just because there's starting to be more and more of, there's a brand of ventilator out there that is from Respironics, it's called the Trilogy. You may see these ventilators, they are essentially a glorified BiPAP,
Yeah,
okay? They work like a BiPAP.
well, I had a client that had it as a BiPAP, but then she had to go get a trach, and
Yeah.
that's what she's using
Yeah.
still.
And it is FDA approved for that.
Okay.
Okay, so it is FDA approved for that. But it operates like a BiPAP, meaning it is not PEEP compensated. And even though you physically dial in the PEEP on the ventilator, that does not make a ventilator PEEP compensated. This is something that I'm emphasizing actually in the curricula for respiratory therapy programs, because we're graduating respiratory therapists who don't understand the terminology. I actually just, somebody who came from Respironics actually just went to work for the company that makes our ventilator. She and I had a 2-hour sit at the national sales meeting. She didn't understand it, and she worked for the company. She thought their ventilator was PEEP compensated because you dial in PEEP, because it's a button on the ventilator and not a dial. That does not make a ventilator PEEP compensated or not PEEP compensated. It has to do with where the PIP is in accordance with the PEEP, okay? So, when we are pressure ventilating somebody, we are giving them a certain amount of pressure, and again, I'm gonna fall back to our primary, our newer ventilators. Let me say one thing since we're on the topic of old LTVs versus new LTVs. The first thing that you'll notice is the new LTVs are purple. So usually when you come into a room and you glance across the room at the ventilator, if it's purple, it usually has a place to dial PEEP into the ventilator. It is PEEP compensated, means the pressure is on top of PEEP, okay? So you'll notice that right away. The external PEEP valve is the other big giveaway, okay? We have obsoleted those old ventilators. That does not mean that if somebody is out there on one, that they have to get off of it right away because it's been obsoleted. Those ventilators are very durable, and they'll run past our support date. They've been obsoleted now for about 2 years. We will support, the company will continue to make parts for them. The FDA requires that it be 7 to 5 years. So we've got at least 5 more years left on those ventilators. So nobody has to go, oh my gosh, we gotta get off this ventilator. What I recommend to people is, ventilators have to have preventative maintenance. And the preventative maintenance on our ventilators is fairly inexpensive. The every 2-year one, we're every 2 years. So the 2-year and the 4-year is pretty inexpensive. The 6-year is expensive. It's like $2,000 to get it PM'd. So what I teach my DMEs, and what you guys can help kind of pay attention to, working together with the RTs from the equipment companies, if your vent is due for a 6-year PM, they should probably trade that ventilator in and get them on one of the new style ventilators. Because they'll spend more on the PM than the ventilator's worth.
What's the PM then?
PM stands for preventative maintenance.
Oh, the maintenance.
All medical devices have to have
Right.
preventative maintenance. Some ventilators it's every year, some ventilators it's every 2 year. We have a new vent out that's every 3 years. So just depending upon the
That's when
durability
they
of
come
the
to the
vent.
home, take the vent and leave you a different vent.
Yep, that's what they do. And it has to go back to the factory usually and get
I have
the,
a question.
Okay.
Since we're going from, say, one of these vents
Yep.
to one of those vents,
Yep.
is that a transition that can be made in the home?
It
or-
can.
Okay, so they don't need to, I mean, because I think that's a lot of the concern is, oh,
Yep. No.
we have to go to the hospital and
No.
transition and.
it
so we
doesn't,
can-
it's the exact same, the
Okay.
ventilator characteristics are exactly the same. Now, if you're going from an LTV to another manufacturer's device, I absolutely recommend, or vice versa, frankly, absolutely recommend a hospital admission. Because just because this ventilator over here says that it does pressure support, flow trigger, blah, 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 if it's not the same manufacturer, it doesn't do it in the same way. And so it's gonna feel very different to the patient, very different. I do not recommend those in the home. Do not recommend them in the home, especially on a patient who can't verbalize to me something is wrong, something feels different, you know. I will say that I have over the years done them, but in the home, the specific one that I remember, and it went quite well. But it was on somebody who was a quad, who worked every day, who was completely able to verbalize to me, no, that doesn't feel right, this feels better, that doesn't feel good. And we used CO2 technology and pulse oximetry, and we did it right. Just coming in and switching ventilators is not doing it right. Now, if we're going from this in the same brand of ventilators, same make, manufacturer, it works the same way, it can be done in the home. If the patient is on pressure control or pressure support, any type of pressure-driven breath, okay, some care needs to be taken in doing that, because there are things in the back menus that we won't go into because you guys won't ever have to deal with it, but they have to be set up the same way on both ventilators. Also, we talked about that PEEP compensation versus not. The setting of pressure support, depending upon the PEEP, will be different on that ventilator than it will be on this ventilator, okay? So the respiratory therapist who's helping you with that, who's coming out from the equipment company, will need to obviously be aware of that, and I hope that at least everybody in this area is. I've worked extensively with them since 2007. I hope everybody's getting it. But that's different. So they will need to work with that, and that's not a go in, throw it on them, I'll see you next month thing. That's, let's spend an hour here together, making sure everything's okay. All right, but that can be done in the home. Switching manufacturers, whether it's going from somebody else's to ours or vice versa. Because we do have a lot of people who, they were okay on another type of device when they were non-invasive, they get trached, they try to stay on that device, it is FDA approved for that, so you can use it for that, but the patient is not tolerating it well, there's multiple reasons for that. So then they want to go to the LTV, because this is more of an ICU style vent. I don't recommend that in the home. That needs to happen in the hospital so that we can track what's going on with the person, okay? So that's when I would recommend a hospitalization for transition, okay? So volume versus pressure. So to sum up pressure, if we're pressure ventilating, so for volume ventilating, we're paying attention to that PIP, right? If we're pressure ventilating, the main thing that we want to track over time is exhaled minute ventilation. And we denote exhaled minute ventilation as a capital V and a capital E. Sorry, we have some strange respiratory insignias here. VE stands for minute ventilation. Is everybody familiar with what minute ventilation is? Kind of, sort of. Minute ventilation is the amount of exhaled air over 1 minute. So simplistically, it's tidal volume times respiratory rate. But usually our patients aren't that simple, because sometimes they breathe more than other times, right? So we track that over time and over 1 minute. So from a very raw standpoint, if we're pressure ventilating, the PIP is going to be the same, but the tidal volume per breath, or the exhaled air per breath, is going to vary. But if we sat there and looked at every single breath, we'd drive ourselves crazy. You want to look at it over 1 minute. Okay? So, this is advanced ventilator nursing practice. There are times when our exhaled minute ventilation is not coming back through the ventilator circuit. Tell me times when that happens. Patient's exhaling, but it's not coming back through the ventilator circuit. They have a big leak. Exactly. Sometimes that leak is intentional, sometimes it is not intentional. Intentional leak is when we purposely put the cuff down to allow the person to vocalize. Sometimes we'll put a speaking valve in line, right? So that's intentional leak. That means that we've intentionally allowed the patient to not exhale back out through their tracheostomy tube, right? So the air is not coming back out through the tube. The air is actually coming up around their vocal cords so that they can vocalize and out through their nose and mouth, okay? So that's a time that we do it intentionally. There are times that it is not intentional, right? Like they chew a hole in their pilot balloon.
That happens.
right? Especially in a Bavona with a water cuff. You know, doesn't one of those water cuffs look like a teething toy? So sometimes you gotta take that booger down inside their shirt, you know, or something like that, because they'll try to chew a hole in that, and then they'll have a leak while the water's leaked out of it. Or in this case of this balloon, air would be in here. So sometimes it's unintentional leak. Okay, so we need to understand the difference in those. The ventilator, our ventilator measures, and all of our ventilators measure exhaled minute ventilation. There's a place for an alarm for it. It'll display what their exhaled minute ventilation is here. There's a low minute volume alarm that we set on here. That low minute volume alarm is very important if we are pressure only ventilating. So if we're not volume ventilating at all, volume plus pressure support, but we're pressure ventilating, either pressure control, AC, assist control, or pressure control with pressure support, that minute ventilation alarm is really important. Sometimes when patients have an intentional leak, like with a speaking valve, we do have to shut that off. I'm going to talk to you more about that when we talk about our 5 buttons, okay? But sometimes you will have to shut that off only when the speaking valve's in line. If we have somebody who's pressure ventilated and their minute ventilation, we should always have something, even if it's 0.1, on that low minute volume alarm. Just had a long talk with some folks at Rankin Jordan about this, and we had a controversy back and forth about it. The fact of the matter is, air follows the path of least resistance. So if you have a patient that is constantly exhaling out around the tracheostomy tube, and no air is coming back out through the tracheostomy tube, air is coming through there, and you don't have a speaking valve on there, then your tube's probably too small, or it's occluded, because that means that the resistance inside that tracheostomy tube is so high that you can squeeze air, that it's easier to squeeze air around the outside of the tube than it is to exhale through the tube. That's not good usually, okay? So, minute ventilation alarm should always be on at least 0.1, never less than that. Do not let anybody or let your nurses be talked into shutting off the low minute volume alarm, especially on pressure ventilated patients, just because. You need an order for that, okay? There are very rare situations where a patient still has a tracheostomy tube because we're waiting to have surgery to fix something in their trachea, and they don't really need the tube to breathe, but it's holding their airway open for some strange reason. It's very, very rare. Very rare. But I have seen it. So I won't say that there aren't exceptions to the rule, just get an order for it. Okay? Because if you shut off your low minute volume alarm, you may have disabled your secondary disconnect alarm, and that's dangerous. Okay, we'll talk more about that when we go
So
through
why
that.
would, because I had a patient with my other company, same problem.
Yep.
They had it set, actually the RT came in, set up the equipment, it was set at 0.1, and I came in and the parents said, it just alarmed and alarmed and alarmed, and we couldn't stand it, so we turned it off. And I said, whoa, you know, that's an order, it has to be on. Well, the RT said we could turn it off.
Yeah. I
So-
would make sure you have that documented
What-
by a physician.
What would cause the alarm not to be able to ever stop? You know what I'm saying? How do you fix it so it
You
doesn't
can't,
alarm?
because there's something else bigger in the picture. If, like I said, air is going to follow the path of least resistance. So now I can't say, because I don't know that case, that there might have been a reason to have a too small of a tracheostomy tube in. Did the tube have a cuff on it?
Yes.
Was there water in the cuff or air in the cuff?
I believe there was, well, I didn't work the case, I was a
Okay.
supervisor, so I was only in a few times, but I believe there was water in the cup.
Okay.
But
If it's a Bavona TTS, which is the tight to shaft water cuff, you should, the idea of a water cuff is that you set it to minimal leak, which means you put in enough water that it occludes so that all the air comes back through the through the tracheostomy tube, and then you slowly back it out until you have a very minimal leak around the tube. Okay? That's how one of those tubes should initially be set up to determine how much water goes in the cup. Then usually what happens is they determine that in the hospital how much volume it takes, and then they say always put 1.5 centimeters or 1.5 mils of water into the cuff. Then what happens is the kid grows. And now 1.5 mils of water doesn't any longer get close to touching the trachea because the trachea grows and gets bigger around. And so you need more water to get to minimal leak. So usually I tell people that if that's happened after time, after they've come home and all of a sudden 5 months later, 6 months later, we're starting to get all these alarms, especially at night, when all the muscles in the neck relax and you get a bigger leak around the tube. We've got water in there. We're putting in our 1.5 mils. Why are we getting all these alarms? It's usually because either they've grown and now we need more water, or they've grown enough that they need a bigger tracheostomy tube. I've seen that happen. I've seen kids stay at home for 3 or 4 years without an admission, and then they come into the hospital crapped out. I saw this actually at a hospital one time when I walked in the door, and from back outside of the kid's room, I could look at the settings, and I said, well, I already know which problem it is. They're like, what? You didn't even see the kid yet. I said, the settings that he's on are for when he went home 3 years ago, not for how big he is now. And so there's a problem. So actually keeping them home, what you guys do, and keeping them home and keeping them from being readmitted is a good thing, but it doesn't, somebody's got to follow up on them. And so all these little things, sometimes, even if they're seen by a pulmonologist, this kid was seen by a pulmonologist, nobody caught it. Until he was doing terrible and ended up in the ICU. And I was like, and I saw it because I was an outsider and came in. It's harder to see when you're living with them growing. You don't see it happening when you're there every day. When I come in and haven't seen the kid for 3 years and all of a sudden I'm looking for a kid this big in the bed and I see one this big, it was obvious to me what was wrong. So sometimes it's just a fresh set of eyes on the situation. So I can't tell you specifically for that patient, but you never want to turn off an alarm just because somebody said it was okay. Get an order for that.
So the respiratory therapist can't say, oh, you can do this.
Without an order for a
Without
low
an
minute
order.
volume alarm, I would not do that. That's one of those things I would not do
And
without an
I
order.
think sometimes the parents think that it's okay if the respiratory therapist said it's
Yeah,
okay.
and a lot of times something, and
So,
for
Depending
sort of
on
in their
what it is.
defense,
As
it
far
depends
as
on what it
changing a
is. Yeah.
setting though, that's,
Yeah, that's a safety setting that there's a really good reason. When we go over alarms, I'll explain to you a little bit more about it, but there's a really good reason that you don't want to do that. You don't want to muck around too much with your alarms out here on the perimeter. Now there are some alarms in the back menus that will pop up on occasion, and the RTs definitely, they can go in and change those per patient, and they don't need orders for that. They can just do that. But to change something critical, like a safety alarm, like low minute volume, I wouldn't do that without a physician order. Okay? How are we doing on time?
It's like 11:05.
Okay. All right. We've had good discussion, but we're running a little behind here. All right, so that's all of our slides. Oh, so the last slide on page 2, or the top upper left-hand corner, sort of brings it all together. It says when we talk about emotive ventilation, we need to know what the volume or pressure is, whether we're volume ventilating or pressure ventilating. We need to know, are they in assist control? Are they in SIMV, synchronized intermittent mandatory ventilation? Are they in SIMV with pressure support, meaning they're getting that boost of pressure? Are they on just CPAP, continuous positive airway pressure? The most common thing that you're going to see in the home setting for a discharge is SIMV with pressure support, either volume or pressure ventilated. Okay? Is everybody familiar with the terms CPAP, PEEP? CPAP and PEEP. Everybody's okay with that? That's positive and either if it's the word PEEP stands for positive and expiratory pressure, CPAP stands for continuous positive airway pressure. They're the same thing. Everybody's clear on that, right? It's just that when we have CPAP, we're not giving any extra pressure or volume above it. And when we call it PEEP, when we're giving that end expiratory pressure and then we're giving something on top of it. Okay? So don't get that too confused. A lot of people, I think that's confusing to them. Sometimes we even throw in another term called EPAP. They really all mean the same thing. They're the amount of air that's left in the chest when the patient completely exhales. Okay? Normal anatomical for that is about 4 centimeters of water pressure. We all have 4 centimeters of water pressure of CPAP right now. Because that's about how much air is left, how much pressure is left in our chest when we exhale. Okay? Questions about that? Does anybody need a break? Everybody's bladder's holding out okay? Okay. We will continue on then. I'm going to go ahead and turn the vent on. Well, first let's go on the outside and talk about the outside of the ventilator, and then we'll turn the vent on. There are 2 filters on the side of the vent that you will need to know to maintain. The first one is your fan filter that cools the electronics. You take this little thing off, you dust this off, or some people may say wash it off and let it air dry before you put it back in. Either way is fine, as long as it stays relatively clean. You will notice, so guys of you who have been doing this for a while, that it eventually gets a dust on the outside of it. You just don't want that dust building up too much on the outside. You want to keep that clean. So we recommend once a week. That's in most houses. It'll keep it from causing you a problem. The only thing you need to know about that is to be careful when you go to take that out. If you use a hemostat or an ink pen or something and you jam it in there to flip it out, if you touch those fan blades in there, that's a no-no. You will get a message that pops up on the ventilator that says HW fault, hardware fault.
I didn't know you could touch the fan.
Yeah, you can. If you
Good
take
thing
this
I've
out,
never done it, I guess. Huh?
yeah.
Good thing.
If you look inside there, you can see the fan in there.
Yeah, I didn't think you could get that.
Yeah, you can get in there. If you put a hemostat or a
Oh.
sharp pen or something in there, you could get in there. I've seen it happen before. If it pops up on the ventilator, hardware fault, if you call the equipment company, the first thing they're going to say is, did somebody stick something in the side of the ventilator? And if they did, get it out. Because it'll stop the fan, and if the fan keeps trying to, it'll burn the fan out, okay? So, remove all foreign objects from the side of the ventilator first. The other thing that can cause that HW fault is if nobody cleans this thing for a really long time and it gets this much dust on it, and the ventilator can't get air in to cool the electronics, it'll give you a hardware fault. I've seen them before, they were just coated. Had a hardware fault, took this off, cleaned it, actually threw that one away because it was so nasty. I actually took an oxygen tubing and blew in there. Ventilator wasn't running on anybody, by the way. Blew it in there to get the dust off of it and put a new filter in there, reset the ventilator, and it started back up, okay? If you get a ventilator or HW hardware fault, it's going to be because of one of those 2 things. Fix whatever it is, shut the ventilator off, turn it back on, it should reset itself. If it does not, that is a hard error. You cannot fix that in the home. The equipment company will have to come get it and swap it out. They will not be happy because that's a preventable error. Okay? So, please be cognizant of that. If you lose one of these little covers, because it popped out and it popped across the room and then the dog ate it or somebody stepped on it, just ask the equipment company. They're not going to run out with it within their 2-hour response time. It's not critical for the vent to run with it, but they're going to want it covered up just as bad as you are because they don't want the ventilator to get a hardware fault and go down either at midnight. So they'll want to bring you out another one of those. They're replaceable.
Just take it off the spare vent and put it on that one.
Very good idea. And then let them know about it so that you can get one for your spare vent. Yep. Second filter, area nut filter. This is the color it's supposed to be, not this color. Okay? So it needs to be washed out once a week with warm soap and water. You squeeze it out, you let it air dry. You don't put it back in there until it's dry. That is the filter that protects the ventilator from large gerbils flying around in the room, like dog hair and cat hair and that kind of stuff. It's the stuff you'll see deposited on the outside of this. Okay? We do not recommend that the ventilator run for more than 20 minutes without one of these in place. That's why you should have two. If you have two ventilators in the house, you have two. Just take one off the other ventilator if you need to. Or ask the DME for an extra one. Okay? Let it air dry. Don't put it back in there wet. Believe it or not, I had somebody who told me that they got them wet on purpose. They thought it would give the patient more moisture.
Oh, no.
They were giving the vent more moisture. I can't believe the vent didn't go down because it had to be sucking water into the ventilator. There is a flow that goes through the ventilator all the time, that bias flow that I talked about, 10 liters per minute going through the vent all the time. So you will not see anything build up in the ventilator unless it's heavy enough that it can fall out and through 10 liters of flow. I say that because every once in a while, first of all, you will usually have a filter, a microbacteria filter off of this side of the vent. If it's a nuisance by the way you have it set up on the chair or something, with a filter sticking out of there, you can get an elbow and reroute it this way, okay? Just ask the equipment company for a 90-degree elbow to go on there. And if they don't know where to get them, have them call me, because I can get them for them. And a filter on there. The reason you want that filter on there is that this is pulling air from the room. This filter is to catch big stuff, not little stuff, okay? The biggest reason that I like to go over this with people is that on that filter that sits here, sometimes you will see a gray dust build up on the ventilator side of the filter. That freaks people out. I'll admit, it freaked me out the first time I saw it. I was like, what the heck is that? And what is on the inside of the ventilator, because that's coming from the vent. After freaking out for a few seconds, I called tech support and they said, one of two things. Do they have a coal or wood stove in the house? And is it winter? Or is it fall and they're cutting beans? Soybeans next door. So soybeans have this nasty, very fine dust when they harvest them. It can come through the ventilator because of that 10 liters of bias flow. It won't rain out in the vent, so don't worry, your ventilator hasn't been contaminated. But the filter will catch it because that's a microbacteria filter. So you'll see it built up on there. So the good news is your patient isn't, their lungs are not being exposed to the bean dust. The bad news is all of ours are. So when my sister had her cancer treatment, they told her she had Southern Illinois lung because we grew up in Southern Illinois. They said everybody has it that grew up in Southern Illinois. It's bean dust. And it gets in your lungs and it's not cancerous or anything. It's just there. And so we're going to catch that. So don't freak out. If you see that on there, just change that filter. Okay? Change that filter. So what about the circuit? Putting a circuit on the vent. The ventilator circuits will come in the package. When you open the package, they will either be little tubing like this is 15 millimeter tubing, or they will be larger tubing, 22 millimeter tubing, pediatric or adult circuit. They will be put together already for you. They will have 4 connections on the end. They will not fit on any other way. This is really simple. You cannot mess this up, right guys? So inside the package, there will also be a little short tubing about like that. If you are using it on a heater, with a heater, a water heater, you need that piece, right? Because that's the piece that goes from the vent to one side of the heater chamber, and then this one goes on the other one. If you're using it on a dry circuit with an HME, does everybody know what HME is? Heat moisture exchanger, okay? Then you don't need that little piece. Throw it away, okay? Because someone is going to try to figure out how to make it fit in line with something, and they're going to mess something up, okay? So if it's with a dry circuit like this, no water chamber, pitch it, okay? It's just going to cause you trouble if you don't. If it's with your heated wire circuit that is blue, like that one on one side, and white on the other side, you need it. Don't throw it away. It's going to go from here to the water chamber, and then your large tubing is going to go on the other one. On those chambers, doesn't matter which way it goes. Okay? Do it to what gives you the most slack. All right? If you're not using a heater, You're gonna have that filter here, and then this is gonna plug straight in. It's the only big hole. You have 3 other holes. You have 3 other tubings. These are your flow tubes, okay? They go back, if you trace them back, they go right up here to the airway. This is what makes this ventilator a very sensitive ICU type vent. It directly measures flow and pressure right at the patient's airway. Doesn't estimate it, doesn't guess, it measures it, okay? So it's gonna be work just like an ICU vent. Those 2 tubings trace back to these 2. They are male and female Luer locks. They will not fit on the other way. If you are confused about male and female, you may have chosen the wrong profession. But they are also color-coded, okay? You cannot mess this up. When you go to plug these in, this is a little trick you will not find in the manual, but it goes a long way to just finger tight securing them and not having disconnections. When you go to plug them in, take it in your hand, turn it back towards you, plug it in, then tighten it down. Do the same thing with the other one. Turn it back towards you, plug it in, then tighten it down. The reason you want to do that is these are Luer locks, but unlike your IV tubing, the outside does not spin. So if you plug it in and then tighten it down, if you don't do that little trick, it'll work, but the tubing will be torqued. And then when you take them out to the living room and you go out to the porch, and after a while, these are going to shake themselves loose, and you're going to get disc sense, disconnect, low pressure alarms, all kinds of crazy things going on, okay? So do that one little trick, and I'll save you lots of time. No male nurses in the room, but you guys may be training some. This is where you get your dig in on your guys. You always tell them, no tools are required to do this, nor should there be, okay? For anyone, do not crank them down so tight in there. Those are plastic. They will break if you crank them down way too tight. I've had to dig them out with hemostats before. Okay? Usually those are paramedics on ambulances, though, using them because they get excited and they crank them and then they snap. Okay? So just finger tight, should be good to go. Okay? The last one is your exhalation valve. It's the only hole left, and it presses straight on. If I trace it back, it goes to my exhalation valve. Okay? This is where my patient's exhaled air comes out. All right? So on your one with your PEEP valve, you've still got your external exhalation valve, but then you also have a PEEP valve on there. So when you're setting up a new circuit on that ventilator, the first thing that you do after you get it on there is, if it's on the patient, if you're switching it out while it's on the patient, go ahead and put it on the patient, eyeball it to whatever PEEP that it's supposed to be, and then read it off of the ventilator, plus or minus 1. Don't stand there and do this until you try to get it exactly, because if there's somebody breathing on it, it's going to be dynamic. You'll be there all day. Okay? Plus or minus 1. If the patient is very PEEP dependent, and a fluctuation of a PEEP of 1 is going to be clinically detrimental to them, they will be on your ventilator with the internal PEEP. Okay? And we've really moved to that purposely for a lot of reasons, one of which is even kids with relatively low PEEPs, 6, 7, if somebody changes the circuit and forgets to set the PEEP, it usually won't harm them right away. 3-4 days down the line, they'll start to get atelectasis, and they'll end up in the emergency department. And Dr. Patel at Children's specifically, he likes his patients to be on this one no matter what, because he's seen that happen before, even with patients with low PEEPs, and he doesn't want to see them in the ED because somebody forgot to set the PEEP valve. Okay? So you'll see him ordering even patients. You know, now all new orders go out with new vents usually, but in the past, that's kind of been a pet peeve of his with builder style vent. Questions about any of that circuitry setup? Okay, we're gonna move to buttons. Oh, wait, I skipped something. Oxygen. This is where your oxygen goes in. It's the only place your oxygen goes in. Okay, don't let any respiratory therapist try to talk you into wiring in something somewhere else. No, it goes right there. That's it. And trust me, you can't give more oxygen than this ventilator will handle into here. There's no reason to put it anywhere else. Okay? real quick mention about giving your oxygen into the ventilator with an oxygen concentrator. It's okay to do that, but you need to know what kind of concentrator you have. They usually come in 3 different types: 3 liter, 5 liter, 3 different types: 3 liter, 5 liter, and 10 liter machines. There are a few 7 liter machines out there, but not very many. Know what you're on, okay? And the reason is that if you have somebody who's on a 5 liter machine because they get their normal bleed in oxygen is either nothing or, a quarter of a liter or something like that. So you've got a lot of play to go up to 5. And so the DME puts out a 5 liter machine. You're only going to get 5 liters out of it. So if the patient goes south on you and you need to crank up the oxygen, you should always have an emergency tank around that you can flip up to 10 or 15 liters. Okay? Because if my concentrator is a 5 liter machine, it doesn't matter how much that ball's bouncing up and down, you're getting 5 liters. That's it. Okay? Same thing with the 10 liter machine. Okay? So, again, just know what kind of tank you have. Make sure your nurses have all put the regulator on a tank and taken it off. Pop the tank open. Know how to line up the pins. Okay? Nothing's more frustrating to somebody to have to do that for the first time in the heat of the moment, and then they don't get it lined up and it goes psh, and it scares the bejesus out of them. There's just no reason for that. Have them do it over and over and over, and have them hear that sound, because it is scary. You guys have probably all had it happen to you at one time or another. I have, but it's not it's not going to harm you. You just got to close the tank and line the pins back up. Okay, so but make sure everybody's done that and feels real comfortable with that, because they may have to do that in an emergency, especially if they're using a concentrator for their primary oxygen source, but their emergency is a tank. Okay. Questions about any of that? Anything on the outside of the vent that you've seen? You're like, what does that do? Okay. All right. Let's move on to buttonology. There are essentially 5 buttons on the front of the ventilator that you're going to need to know. The first one is the on standby button. I may have to plug this in, but I'm not sure. We'll see. The first one is the on standby button. That's how you turn the ventilator on. That's how you turn the ventilator off. Okay? If you go into a home on one of our purple ventilators, the 1150 or the 1100, and when you turn the ventilator on, it asks you a question. It says, same patient. Your answer to that in the moment is yes. You press the select button to say same patient. But call the DME and have them on their next opportunity come out and fix that, so that every time your family or your nurses turn the ventilator on, it automatically goes to that patient's settings. That feature is for emergency and disaster preparedness, and you're not in emergency or disaster preparedness, okay? So there's a way to shut that feature off, and a lot of people just haven't done it, and so it creates confusion in the home. When people turn the vent on, it's saying same patient, new patient. What does that mean? And then people start pushing buttons, and no. Okay, so it's always the same patient, obviously, in the home. So say same patient right now, but call the DME, have them come out. Again, if they say to your nurse, well, you can't shut that off, have them call me. I will explain to them how to go in the back menus and shut it off, or I'll come and do it myself. It's a very simple step, okay? But it's nothing you guys need to worry about except for that it shouldn't do it, okay? You will notice, because I am not plugged into my AC power supply or a Sprint Pack external power supply, that when my ventilator is running, it dims out all the lights. That is to try to save energy. Your ventilator has a 1-hour internal battery, but it's really not designed to run it on all the time. That's your battery to get you from the bedroom to the living room, or from the tub room to the bedroom. Okay, so little short 15-minute intervals running on that, perfectly fine. That's what it's for. It's also there for emergency backup. But if you're going to go out on the porch and there's no AC close to you, then that's fine. Make sure you have an external battery with you. where you're running off of the power in the power chair. Okay?
How long is the external?
This is a 5-hour battery. Okay? These should be 2.5 hours per pack if they're fully charged. Alright?
Should we let those run down?
No.
Okay.
These batteries are lithium ion. Lithium ion batteries, whether it's in a ventilator, an oxygen concentrator, whatever it is, they like to be charged. So when you have the opportunity, you should plug them in. If you only have one of these things and you have a setup at the bedside and then you have a vent in the bag, usually this will be on the vent in the bag, so leave it plugged in. Okay, this just slides into the front of the pack, or you may have one of those metal carriers, a Freedom carrier. Those are really good for if you have a patient that's in a wheelchair, a mobile chair especially, because then it gets banged against the doorways and stuff, and it protects the ventilator and everything. So metal carriers are good for power chairs, but leave that one plugged in. If you only have your extra battery and you want to run your extra battery on here because you don't ever go to that other pack unless you're going to the hospital or something, there is a holder that you can get to go on the stand. Okay? What I don't like to see is this like this. Okay? And then an AC, and this is like flinging out here in the wind. Because what's going to happen, that's going to get knocked off, and it's going to snap this. Okay? Or I have seen them where people have tried to do this with it somehow. You know, and then you've got the AC power supply, and you've got this, and there's a bracket goes on here. So if you're going to use your power supply on your vent with the roll-around stand, you want to have a bracket to slide that into so that it's not just flipping around, because this will inevitably break loose and break the clip or fall off and hit you in the foot, you know. So, bracket.
So lithium batteries do not need to be discharged.
No. They like to stay charged. That will actually help them last longer. Okay?
The other big ones though.
The big marine battery. Yes.
do.
They're different.
Okay. And they're
They're
8
different.
hours or?
Those are usually 6 to 8 hour batteries. Yep, depending upon what ones they are. That's a good question. Because a lot of people, if you don't have a generator in the home, they'll have one of those someplace in the house. And they'll give you instructions. It depends upon what kind of, whether it's nickel metal hydride or lead acid, on how you want to maintain it. So the equipment company will give you directions on what to do with that. They may even come out and help you to do it. To charge and discharge those and make sure that they're holding a charge. Sometimes they also use those if there's no generator in the home, because they can actually have a power strip on them, if you've seen that one, because then you can plug your portable suction into it. So if the power goes out, it allows them more time in a disaster type situation, like a bad ice storm or something, because you've got ability to run your suction and your ventilator and a pulse ox off of it or something. Okay? So your first button, again, on standby, you press it to turn it on, you press it to turn it off. Press and hold it for 3 full seconds and it'll shut the ventilator off. Okay? The next button across the panel that you need to be familiar with is that manual breath button. It's in the center bottom of the screen. Manual breath. That's your bag your patient without disconnect them. Every time you press that manual breath button, it will give them 1 ventilator breath. Okay, so it won't overventilate them, it won't underventilate them, gives them just the right amount of ventilation. It will also synchronize with them, so it's much, much, much better than bagging. Okay, there are times in urgent situations that you have to disconnect and bag. If you get a plug in the trach and you're trying to figure out, you're trying to feel what's going on, the ventilator's alarming high pressure, but you just need to make sure that can I move air or not move air? You're going to have to disconnect and bag. But most of the time, for a basic patient coughs, ventilator high pressures, I look over, yeah, you need suctioned. You're not going to take the patient off the ventilator for that. You're going to suction them. You're going to give them a couple extra breaths if they need it. Turn their oxygen up a little bit if we need to. Get them all comfy. Everything's good. turn the oxygen back down, we're happy. And we've never disconnected that. Okay? So use that manual breath button. It's your friend. The next button across that you need to know is control lock. Control lock should always be illuminated. Should always be green. It is your friend. It is so that no little hands, other little hands in the house can accidentally make changes. You may also need to have, if you have other kids in the house, you need to have that thing that slides over the front. Some of you have probably seen that. Slides over the front so that all you can see is the patient's exhaled values and the silence reset button. So if there's other kids in the house, this should be locked and you should have the panel on it. If you need to give extra breaths, you slide the panel back. You can give the extra breaths, you slide the panel back, okay? So you don't want, the little brother and sister hyperventilating their sibling by figuring out that that makes them have a breath. Okay, so that kids can figure out amazing things. So slide it on, slide it back, you should be good to go, okay? Control lock. If you do need to unlock it, when will you need to unlock it? Well, if you're going to have to turn the ventilator off to go to the other ventilator, or because they're only on the ventilator part of the day, we're going to need to unlock it. And if we have to do the next thing that I'm going to show you, which is manipulate the low minute volume alarm, you have to press and hold it for 3 full seconds, and it will unlock the front panel. It will dim this light out, and then you can shut the ventilator off, go to the other vent, or whatever you need to do. Okay? Next, low minute volume alarm. We have talked about this already, especially when my patient is in pressure ventilation. The low minute volume alarm is my friend because we have 3 primary alarms on the front of a ventilator. High pressure, and that is my pressure pop-off too, by the way. That is my pressure pop-off, especially for you trainer nurses. If you go into a home and you see somebody's run that sky high, and you go, whoa, 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 why is that at 80? And they say, oh, well, every time I give him a bath, it high pressures, we just want to get rid of those alarms, so we ran that up. No, 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 that is your pop-off, which means that's where, at what point, it releases pressure from the ventilator circuit to ambient, okay? It will go up to 100 centimeters of water pressure. We have to do that because our ventilator is used in critical care as well. A version of our ventilator is used by the military to ventilate big guys with chest traumas. So we have to be able to deliver big pressures and not alarm for that. But your kids don't need that, and your patients don't need that, okay? Or they wouldn't be at home, they'd be in the hospital. So no running that thing up, okay? It should be set on something reasonable, whatever they come home on. Usually the rule of thumb is don't go above 60 unless there's a reason. Sometimes they'll be set a little bit lower than that, but that's usually a good rule of thumb. The second alarm across here is your low pressure alarm. Again, you guys won't ever have to change, should never have to change that. That will always be set above PEEP, okay? And if it's set on a specific number, please do not, and teach the nurses, please do not manipulate it. There's probably a reason it is set higher. So I've had people say, well, that only needs to be above PEEP, and my PEEP was 5 and it was set on 10, so I don't want to get any nuisance alarms, so I'm going to put it at 6. Here's the reason you don't want to do that. If you have a patient that has a speaking valve, so when we have a speaking valve, we do have to disable or turn the low minute volume alarm down to dashes, which means it's off, right? So if I have to do that, put in a speaking valve, I'm going to press that button. I'm going to turn this until I see dashes, turn my dial, and then I'm going to press it again. When you see dashes in a window, it means that parameter or alarm is turned off. Okay? So why would you need to do that when you put a speaking valve in? Well, what does a speaking valve do? A speaking valve allows air to come through the tracheostomy tube, through the ventilator, but does not allow it to come back out that way. because we're trying to purposely force the air up around the vocal cords, right? So, a couple of main things that you need to know anytime you're using a speaking valve is if the patient has a cough, it must be deflated, right? Because if air can go in but can't go out that way, and it can't get out this way, where's it gonna go? Poof. Okay? So, you gotta have your cuff down. A lot of doctors will not discharge patients from the hospital with a cuff and a speaking valve. Okay? I hate that they feel that uncomfortable with us. Because for some kids, that's a really good thing. They do need that cuff up at night to ventilate them or to protect their airway after feedings or something like that. But by darn it, we gotta teach kids how to talk. Okay? So I love speaking valves. I'm a big proponent of them. I do understand, because I know docs who've had bad experiences, that the cuff didn't get put down and the kid ended up in the ED with a pneumo. Okay? So I get that. I understand it. But I'm going to be out here preaching the gospel on it as much as I can to make sure that you guys are training your nurses. Make sure that cuff is down, because I hate to see a kid not to get the opportunity to vocalize because they're afraid that we can't take care of them in the home. Okay? So that's really important. So our cuff is down. Air is going to come out through the nose and mouth, meaning it's not going to come back out through the circuit. So we're going to have 0 exhaled minute volume measured by the ventilator. So if you don't disable that, turn it to dashes, the vent's just going to alarm all the time. Okay? So you do need to disable it when you take which puts the speaking valve in. When you take the speaking valve out, reset it. Okay? So the sequence of doing so should look like this. Your ventilator should be locked because you're good nurses, right? So you're going to unlock it by pressing and holding for 3 seconds. You're going to press the low minute volume. You're going to turn the dial until you get dashes. Then you're going to relock the front of the ventilator. Now we take the speaking valve out because they're done. Because we're going to put them down for a nap or because it's bedtime. No speaking valves while we sleep. No reason for it. Speaking valves are for vocalization, to improve swallowing during a feeding, and we're not going to be doing either one of those while we're asleep. Okay? Take it out. It's too dangerous to leave it in there. So because we want to turn that low minute volume alarm back on. Okay? And it creates airway resistance. No sense in having airway resistance while you're sleeping. Okay? So we're going to do the opposite. Now we're going to unlock it. We're going to press it. We're going to turn it back to whatever it was supposed to be set on. And press it. And then we're going to relock the front of the ventilator. Okay? Sound good? Alright. So, your 2 disconnect alarms that you have on your ventilator are your low pressure and your low minute volume alarm. Okay? So when you disable your low minute volume alarm, your low pressure is now your only disconnect alarm. It's the only way for us to know if the patient is disconnected. Okay? So, here's the reason why you don't want to go messing with this. And actually in the training that we do at St. Louis Children's, we actually put a trach and a speaking valve on here and demonstrate it to people that you can actually disconnect the ventilator, have a tracheostomy tube flipping in the wind with a decannulated kid, and if this isn't set high enough, the vent won't alarm. Because we have this disabled, there's no air coming back through here, so we've disabled the low minute volume alarm so it didn't nuisance on us. And if we don't have that set high enough, the ventilator will not alarm. Why? Low pressure. There can't be pressure in there. There can be pressure in there. If you have a speaking valve, that's what it actually does. It creates pressure, and then you put it on a little bitty tube like this, and you've got enough flow and resistance in here, there is pressure in there. Okay? So that's why you never let a kid sleep with a speaking valve on, because you want to re-enable that low minute volume alarm. okay? So that if they do come disconnected, the ventilator circuit gets lodged in the blanket or the pillows or something, and it creates back pressure, you've still got a secondary alarm on there. Make sense? Okay, cool. So the last button that you guys need to know is silence reset. Okay? Everybody always tells me that's the first button I want to know. Make the ventilator be quiet, right? Silence reset will silence the ventilator for 2 minutes. It will also reset, if you keep pressing it, it will reset any displayed alarms that have popped up. All right? So that's silence and reset. The reason I teach that last is because it's really the last thing you need to worry about when the ventilator alarms. What's the first thing we should worry about?
The patient.
The patient. Look at the patient. Okay? So, there have been instances where, and it's been caught on videotape, with nanny cams nurses, and I saw it the first time on Fox News, of a nurse standing in front of the LTV ventilator, silencing the ventilator, staring at the ventilator, can't figure out what's going on, never looking at the kid in the bed, and the whole thing was out. Kid was decannulated, sitting right beside him, even on the grainy film where they were nanny camming her, videoed, and they started doing it because they thought she was sleeping on purpose. If anybody of you saw that story, this has been several years ago now, they thought she was sleeping on purpose, and not only was she sleeping on purpose, but they happened to catch a critical incident on film. When the parents came in, of course, who do they look at first? Their kid. They see the whole thing out here, mom shoves it back in, starts bagging the patient, or child, starts bagging, check for a pulse, dad starts doing compressions, because kid's heart rate was less than 40. The nurse did the first right thing she did all night long, which was call 911. Got an ambulance in. That kid actually went back home from St. Louis Children's, survived and went back home. Not with that nurse. So always, always, always look at the patient first. Always look at the patient first. Never silence it and leave the room. Because a lot of times, you know, the vent will alarm, oh, we saw they were disconnected, so we hit silence, we reconnect them, and then we knew what the problem was, they're fine, and so now we go out to get linens, or we're going out to do something else. Just hit it again, so that it's not illuminated, and then that way, if they have an alarm, again, right away, it'll alert you. If you walk out of the room with it red, it's silenced for 2 minutes, so if they have another incident, you're not going to know about it for 2 whole minutes, okay? So just make sure that it's not red, if you have to leave the room for any reason. That's alarms. Other questions about that? Okay. Let's go over error messages, going back to the handout.
We have about 15 minutes more.
Okay. The upper right-hand corner, the slide that says error messages, disc sense. The disc sense message, disc sense means that the ventilator is not sensing flow in these 2 flow tubes. Okay? So let's say, for example, the ventilator alarms, you glance over at it, it says disc sense. What do you do first? Check the patient. Are they disconnected? Well, there's your problem. Reconnect them. Silence the ventilator. Reset those messages. Watch them. Did it clear the problem? Or is it still alarming disc sense? Okay? So always start at the patient and work your way back. If it's not something obvious, like the patient's disconnected, start working your way back through the setup for any disconnections or loose tubings. It has something to do, if you make it all the way back to these guys, it has something to do with these 2 tubings. They're cracked, they're broken, they're pinched, okay? They're pinched here because something's leaned up against where they connect into the ventilator. They're loose at the vent. Or if you have the water chamber, they have water in them. Water is our enemy, isn't it? Water is our enemy. We love humidity. Well, we don't love humidity. We love our patients to get humidity. We hate water. Humidity cannot carry viruses or bacteria. So if all your patient is getting is humidity from that water heater, wonderful. That's what we want. Can't carry bacteria and viruses, can't infect them, even if something's in there. That's why we always trace water in the circuit back to the heater. Don't ever come toward the patient, even if you've disconnected. So once in a while, you'll get a little water condensation build up in here. That condensation occurs because there's a temperature differential between the water chamber and the patient. Fanning it and shaking it makes it worse. Much worse. Having a fan blowing on it makes it worse. Okay? Moving the tubings around makes it worse. Why? Because those are all things that cool the circuit between the water chamber and the patient. Okay? So we want to try to empty those. We want to try to keep big giant temperature gradients between the patient and the heater from occurring. Sometimes you'll see people cover the temp probe or the circuit with something. They actually make called a circuit cozy. They make a thing that can go onto the circuit. They're actually made for CPAP machines, but they work on ventilator tubing sometimes. Work with your respiratory therapist from the equipment company if you have ungodly amounts of excess water, because there may be ways to get it to decrease. You're never going to completely eliminate it, because in the home, these are designed to work in hospitals, and the temperature and the air gradient is much more controlled in a hospital than it is in a home. And so it's very difficult to not have some water. So the question just came up, what do I do if there's water in there? How do I get it out? Well, this is one of the only times that you disconnect from the patient and go towards the end of the circuit. If you can get it out of there by sort of trying to squeeze it away from there, then you want to do that, okay? You can tap it out. Sometimes you can squeeze it out of there a little bit. You see a water droplet in there, you can get it out. If you can't get it out, you have to change the circuit, okay? It does not mean that the circuit is bad. It means that water was in it. So what I tell people to do is take that circuit off, put another circuit on. Once you get the patient all settled, everything's happy, take that circuit and hang it over the shower rod. Let it dry out. You can reuse that circuit for up to 30 days, okay? So you should always, when circuits are changed, you should always have something on them or denoting a little piece of tape tab that says when I changed the circuit, unless even if the equipment company people, the RTs, come out and change your circuits for you, you guys should still always, if you have to change a circuit, you should tag it when you changed it, date and time, just like you do your saline when you open it and all that kind of stuff. That way you'll know if a circuit is still good or not. You will follow the circuit change rules by the Durable Medical Equipment Company. Some of them have guidelines that tell you they want you to change the circuit every week, every 2 weeks, once a month. Don't go longer. I wouldn't go longer than once a month, but once a month is perfectly fine. It's what the literature says. The literature says once a month or if visibly soiled or damaged. Okay? So that's fine. But some companies want you to change it more often, especially on heated wire circuits, because the heater wires do get less efficient over time and they get more water. So if your company's policy says change the circuit once a month on a heated wire circuit, and you notice on week 3 and week 4, it is a freaking nightmare dumping water out, it's getting in the lines, it's a big mess, talk to them about that and say, listen, we're tracking this and here's how we're having to deal with water issues. Sometimes they'll say, you know what, let me get you a couple extra circuits, change it every 2 weeks, and that'll help decrease that. And it's going to be different from house to house. So they can't really have set rules. They usually have a policy and procedure guideline, and then they say, and changes of this per discretion of the respiratory therapist, or something like that. So that allows them to give you some flexibility to change the circuit if there's a real reason to need to change it intermittently. Yes?
Should a patient be moved to the secondary or second vent on a regular basis? Because I have a lot of families that never, we do this every winter to make sure that they put them on that vent and it's working properly, because they don't even change the circuits. I mean, they everything is, they don't do any, so realistically we should probably switch
You should run the ventilator at least once a month, and a flow test or circuit test needs to be done on that ventilator once a month. Okay? So
Isn't
even if
that-
you're not running it,
Isn't that through the I mean,
the Gerbil Medical
Yeah,
Equipment
they
Company
send
will
them out.
usually do
yeah,
it.
and
They come out once a month usually anyway.
Right.
Now I will tell you that a lot of the equipment companies are starting to look at, and this is allowed by policy and procedure by their credentialing body, is that they can put patients on what's called maintenance, which means they don't ever have problems, they're good to go. We're not gonna go out and see them with a clinical respiratory therapist except for every 3 months unless there's a problem, okay? So if they put you on maintenance and they say, you know what, nursing out here is awesome, you guys do a great job, this family does a great job, there's no reason for us to come out here, you guys order your supplies as needed, we'll send a driver out with them. And they, quite frankly, they do that to reduce costs because they make very little money on particularly pediatric ventilator patients. A little bit better in Missouri than Illinois. Illinois, it's very difficult for equipment companies to even do it because they don't pay very much and they don't pay their bills. So, which makes it even worse. So if you have an Illinois case, that's even worse. So it's okay, work through that with people, with your DME company, but if they put you on maintenance, somebody has to be trained to do that flow test once a month, okay? Because that's your verification that if you need to use that ventilator, it's gonna work, okay? Now, circuit, there's a circuit on it. What about changing that circuit once a month? As long as the circuit is capped appropriately with either a test lung, like you see there, an HME, or a cap. They make these little red caps that you put on the end of a ventilator circuit that keeps it sealed, okay? You don't want, this.
with a Ziploc bag.
Wait,
Yeah.
yeah,
Exactly.
no, we don't want that.
Yeah.
Yep, gloves.
Yeah.
Seen that
Yeah.
too.
Yeah,
Yeah.
gloves are common.
Yeah, so that's a better way. And if you're disconnecting, I mean, it's common sense that, if you have an HME on there, that's actually a great way to cap a circuit. Because then if you go to use it, just take that HME off, throw it away, put a new HME on it. And the HME doesn't allow anything to get in the circuit. Also the little red caps are good because they're actually better than a bag or a test lung because a test lung could get bacteria in it. Or a glove or a Ziploc bag could get bacteria in it and house something in there that grows. So anything clean and dry is what we're looking for. Okay?
I have a question.
Yes, ma'am.
One of my big cases, the RT wants them to do a leak test on the back of the vent every shift. They have 2 shifts a day.
That's not necessary. Let's talk offline about who the equipment company is,
Okay.
and we'll get that rectified. That's not
Okay.
necessary. That's not necessary.
It's not in St. Louis.
Okay. All right. So we talked about DiscSense, hardware fault, HW fault. We talked about that. We're not going to talk about that anymore. Just don't do that kind of stuff, and it doesn't happen. Low BATT. So when I disconnect my ventilator from the AC power or from the battery pack, I'm going to get a message on there that says power loss. Okay? Power loss simply means that the ventilator has lost power, external power to it. It's just to alert us, hey, we're running on our internal battery. That's a 1-hour battery. Figure something out, okay? The lights will dim eventually over time. To get the information to come back up, you press any button and it'll pop up. That's power loss. Low BATT, you do not want to see that, okay? That means that you have run your internal battery down so low that you only have 10 minutes remaining. It will start flashing low BATT, and you can silence it for 2 minutes, but it will immediately start again because you had 10 minutes, okay? So get the external battery, get AC power, or get the bag, or the other ventilator, because you're going to need something to be able to ventilate the patient. It's only going to last 10 more minutes, and then it's going to shut down. Don't get there, and then you don't have to worry about it, okay? But that's what it means. What about when the numbers are flashing? Sometimes my pressure support or my pressure control number flashes, and sometimes it doesn't. The bottom line is, it's okay. All right? It has to do with some back settings that are set before the patient leaves to go home at the hospital. It has to do with Plassel's law of flow deceleration. Couple-hour lecture, not going to go there. Okay? Just know it's okay. It's okay for it to do that. It's going to happen on occasion. Other stuff, other things that you need to know. HP delay. HP delay is a feature that's specific to our ventilator. We'll love this feature. The RTs at the hospital have the ability to set this up before discharge. Your home RTs can set it up if you're getting a lot of nuisance alarms for a cough. So if a patient can cough and clear their own secretions, fine, I don't care. I don't want to know about that, right? But if they can't, we want to know. So the ventilator is designed to alarm every time they hit high pressure. But it also has a feature in the back menus called HP delay. It allows you to set it up so that the patient can cough twice consecutively. You will get a flash on the screen high pressure, but you won't get an audible, okay? So if you ever see that, flash on the screen high pressure, but it doesn't audible, there's nothing wrong with the ventilator. It's set up for a high pressure delay. That's to allow you and the patient some peace and quiet when they cough and can clear their own secretions. Please know that if it is going to pop off at the high pressure, so their lungs aren't going to see too much pressure, and if it occurs more than twice, the ventilator will start audibly alarming as well. Okay? So it's a really nice feature. Turning the low minute volume alarm off, we talked about that already. Know that when you put that on dashes, you will start to get a message that will scroll in here that says LMV off. It's just to remind you that you've shut that off. You need to reinstitute it when you take the speaking valve out of place. Other alarm messages. If you have other alarm messages that pop up in here, the alarm messages should be pretty self-explanatory, high pressure, low pressure. Once in a while you'll get something. This one I created just so that you could see it. High F off. The ventilator is not cursing at you. It means that the ventilator, there is a high respiratory rate alarm that is set in the back menus by the RTs at the hospital before the patient goes home. If somebody turns that to the off position, then it will say, on occasion, it'll pop up high F off. It's just to remind the caregivers that you don't have a high respiratory rate alarm set. And that's fine. That's one of those alarms that the RTs have discretion on, turn on or off for different reasons. So that's all the other alarms. Where can I find more information? Carefusion.com, that's the manufacturer. My email address. I may have to change my email because I had spam go out on my email at like 2 o'clock in the morning last night. And I've already had calls about it today. I've sent messages out to a lot of people saying, I'm so sorry. I don't know what happened, but so I may have to change my email. If I do, I will contact you and you can let especially the trainer folks know. I may have to change my email address. It's going to make me sad because I've had this
Sometimes
one
it
for a
just
long time.
clones it.
I know, it's weird. So hopefully it was just a single incident. SpiritusConsultants.com, that is my company that I own. You can get more information on how to get in touch with us, how to get in touch with the per diem people that work for us. CEU programs, new products and stuff are all on there. You guys can look at that. We also have links on there occasionally to different kinds of videos and stuff like that that you can use for training purposes. You can go to all of those. That is it. We're about 5 minutes over. I apologize.